Okay. For the last 27 years, I've been a patient advocate and vocally opposed euthanasia and assisted suicide. I've been involved in the pro-life movement for about 40 years. A good friend of mine called me one day. We were living in Montana, and she said to me, "Julie, what do you know about living wills?" I had never heard of them. And so I did some research, and I found out a lot. Montana, where we were living, had just passed a living will law that year called the Rights of the Terminally Ill Act. Alex made reference to that when he talked about the Baxter case, the assisted suicide case in Montana that semi-legalized assisted suicide. But back in 1985, I was telling people that this is exactly what that law would lead to, because it gave doctors immunity for killing patients by dehydration. So if they could kill them by dehydration, why couldn't they kill them by a lethal injection or by giving them drugs to kill themselves? So I was warning people about this, and people said, "Oh, Julie, you're crazy, you're radical." Well, I'm used to that because people have been saying that for many years. But now people are sitting up and taking notice. Even my relatives used to think I was a little bit crazy. But it's true that we are being killed. We have a geriatric society now, and we have to do something about the problem. And we are the problem. Back when I got involved in this, I wasn't part of the problem yet. But I just recently turned 62, and now I'm part of the problem. I would like to begin by showing you a picture that a friend sent me. She thought this was charming. Here's a little deer. He only weighed a few ounces. He was delivered by cesarean section when his mother was hit by a car. And they tube fed him. They had him in an incubator. Little bitty thing. He survived, was released into the wild and probably got hit by a car. But they treated this little deer better than they treat most human beings. Alex mentioned Peter Singer. Peter Singer would have approved. He thinks that pigs are more intelligent than newborn babies, and so therefore they have more of a right to life. This is what we're up against. Animals have rights. Humans are wronged. My subject today is going to be on how to protect yourself. Every day we find more proof that what's accepted as good and true is being turned on its head. Mary Warnock, a British baroness who is considered an expert in ethics in England, recently said at a forum for ethics in medicine that it is genuinely wicked for doctors to refuse to kill patients who want to die. The reasons given for purposely ending the lives of certain people can sound so convincing, but they're all deceptions. Over and over this morning, you've heard people talk about the lies we're being told, the deceptions that are being foisted upon us. Mark Twain once said that a lie can travel halfway around the world while the truth is putting its shoes on. Let's put our shoes on. Our families, our friends, our countrymen, they all need to hear the truth, and they need to hear it from us because they're not getting it from the media. Killing medically vulnerable people always was and always will be genuinely wicked. It is a crime against humanity. Twisted arguments that say otherwise are simply wrong. And we need to stand up and say, this is wrong. If we see it happening to a loved one, we have to defend their right to life. We cannot say, what can I do? It's that kind of weakness that has gotten us into this mess in the first place. We know that something's not right, but we're afraid to speak up. It's time to speak up. We have nothing to lose. We're going to be killed anyway. We might as well go out shouting. I've already heard Alex define euthanasia. I would say that euthanasia is putting an end to the lives of handicapped, elderly, or sick persons allegedly for their benefit, not because they're suffering. We can deal with suffering. We have all the tools at our disposal to handle pain control. We can sedate them if it becomes intractable and there's no other way to treat it. But we don't have to dehydrate them to death while they're under sedation. There are so many things that we can do to help people today, both emotionally, physically. We have so many more tools than we ever had before, and now we're saying that the solution to human suffering is to kill people, when we don't even have to suffer all that much anymore. We're going to talk today about advance directives for health care. These are legal documents by which you say what you want done or not done when you become ill and can no longer speak for yourself. I would suggest that you never sign a document that says, I don't want this or I don't want that. Assign someone, an agent, who can make decisions for you. On my table, there's the Protective Medical Decisions document from the Patients' Rights Council. It's a very good document. It allows you to assign an agent to make your decisions for you if you can't. And the reason that's so important is you can't base decisions on some guesswork about what might happen to you in the future. You have to base your decisions on current information and current treatment options. And you can't know those until it actually happens. Otherwise, it's just all guesswork. So having an agent, someone you trust to make decisions for you, is your best option. Be sure that you never put in writing circumstances under which you would rather be dead, because believe me, those circumstances will be stretched. Advance directives can be used to license euthanasia. If you do not want to license euthanasia or give doctors and others in the healthcare profession a license to kill you, and they may not even want to kill you, you may be tying the hands of a very good physician whose skill could save your life by signing a living will or an advance directive where you refuse particular kinds of treatment. As Ron said, the Euthanasia Educational Council was the group that introduced the first living will. They introduced that in 1967 as the first step towards the social and legal acceptance of euthanasia. A mere 23 years later, the federal government passed the Patient Self-Determination Act. Now that sounds like a really benign name, self-determination. Who doesn't want to self-determine? Who doesn't want to make their own decisions? But what the law actually says is that hospitals have to introduce people and educate them about their right to die, their right to sign a living will or an advance directive of some sort. In 1990, Congress passed the Patient Self-Determination Act, and it penalizes hospitals who do not promote living wills by taking away federal funding, Medicare, Medicaid reimbursements, et cetera. And no healthcare facility can exist today without accepting federal funds of some sort. So therefore, that means that every time you go into a hospital, you are going to be asked, do you have an advance directive for healthcare? And if you say no, they're going to give you one. Do not sign the document that they give you. Go prepared with your own carefully prepared protective medical decisions document with your agent named, and preferably with your agent by your side. But remember, it only took 23 years from the time that the living will was first introduced for the federal government to endorse and enforce the right to die. What exactly is it that the federal government is endorsing? Well, the Minnesota Healthcare Directives Law states that nothing in this chapter may be construed to condone, authorize, or approve mercy killing or euthanasia. That's a lie. If euthanasia is considered killing people by acts of omission. But the law, as was mentioned earlier, has said that euthanasia is not an omission. Euthanasia is an act, like a lethal injection or some other form of direct killing. But euthanasia, it can be an act of omission, taking away a person's food and water, taking away insulin, taking away kidney dialysis against the person's wishes. I'm not saying that people have to accept every treatment. What I'm saying is that when you take something away from people when they want it, that's inhumane. That's wrong. That causes their death. Knowingly or not, you may be signing a license to kill when you sign one of the documents that's approved by the state of Minnesota or any other state for that matter. And don't assume that because a document comes from your church or from your doctor or from your trusted lawyer that it is a good document. Because words have meanings, and they don't understand what all of these words mean either, and they will be interpreted by someone other than the doctor who may have suggested that you sign this particular document. Nowadays in hospital, most people see hospitalists. The hospitalists are taking care of people. Their doctors, most people don't even know. They're not their own personal physician who they've known for years. It's some strange doctor who takes care of them while they're in the hospital. I had that experience myself when I was in the hospital in Stevens Point, Wisconsin. I had a wonderful doctor, and I got into the hospital, and I had a doctor called a hospitalist, and I saw him once in 3 days. But he signed all my orders. So we have to be really careful. Wisconsin's law says that a person has to be terminally ill and permanently unconscious before their living will or their advance directive can go into play, before it can become effective. Well, Minnesota does not even have those requirements. Anybody, for any reason, can refuse treatment. You don't have to be terminally ill. You don't have to be permanently unconscious. Even those weak restrictions are not present in the Minnesota law. But the Wisconsin law does have those restrictions, and they have no teeth. Take, for example, there was a case there that we almost got sued over, Pro-Life Wisconsin and I did, because we said in the newspaper that it was an act of murder. Well, Chad Simon was a Catholic, and the Catechism says that taking away a person's food and fluids in order to kill them is a murderous act, and so we just told it like it was, and the hospice he was in threatened to sue us. But Chad Simons was a Marine Staff Sergeant. He was wounded with a roadside bomb in Iraq and was flown stateside to be treated. He was in rehab for a while and was doing quite well when his wife decided that he'd be better off dead. Chad had signed a living will before he went into the service, and so his brain injuries were the reason that his wife wanted him dead. He was no longer the man that she knew. So she had him admitted to hospice, and they started the process of dehydrating him to death. I get a call from his great aunt a few days later when she finds out what's happening, and she says, "What can we do? His wife is having him killed." And he had signed a living will. There wasn't a thing the family could do. His best friend told the newspaper that Chad was not in a persistent vegetative state, that he was conscious, that he was saying yes or no when asked questions, and that he told him he wanted to live. But Chad was killed. The living will sealed his fate. His wife got her way. And anybody who criticized that decision publicly was threatened with a lawsuit by the hospice that killed him. He wasn't killed by the roadside bomb. He was killed by dehydration, by those who were supposed to be taking care of him.
Can you tell us what hospice that was?
Yes, I can. It is the Don and Marilyn Anderson Hospice Care Center in Madison, Wisconsin. The medical ethics and bioethics are two different things. It used to be that we had traditional medical ethics. Traditional medical ethics was a guide to determining what was right and wrong in a given situation, and its premise was we don't do any harm to anyone. Modern bioethics, on the other hand, is more akin to veterinary ethics. It determines who should live and who should die, and who can be used as experimental guinea pigs, and then it justifies those decisions. So be very wary of bioethics committees or anyone who calls themselves a bioethicist. And I know some good bioethicists. There are several. Wesley Smith calls himself a bioethicist, and I generally trust what he has to say. So there are some people who call themselves bioethicists who are trustworthy. But in the main, when you hear about a bioethics committee or an ethics committee at a hospital now, we're not talking about someone who bases their decisions on traditional medical ethics. We're talking about someone who decides who should live and who should die, and then says why they think this is so. And usually their decisions hold sway in the hospital. Excuse me. In the 1970s, bioethicists argued that it should be acceptable to withdraw feeding tubes from people with severe brain damage in order to allow them to die. Do you realize that people with severe brain damage are treated worse than a dog? If you starved a dog to death or a horse to death, you'd probably end up in jail. But you can starve, or dehydrate, I should say. They're not going to starve to death. If you could dehydrate a human being to death, and you wouldn't even get a slap on the wrist. In fact, it's accepted public policy now, and it has been expanded to cover just about anybody for just about any reason. The next step was voluntary stopping of eating and drinking. VSED, it's called for short. Jane Gross was a retired reporter for the New York Times, and she's written a book called Bittersweet Season. It's about helping her 88-year-old mother to die by VSED, voluntary stopping of eating and drinking. The nursing home staff helped with this. They kept her comfortable while she dehydrated to death. It took 13 days, and Jane wrote, "I was twitching with impatience. I wanted my mother to hurry up and die." The elderly volunteering to die of thirst and their children and caregivers applauding and aiding them is a sign of a very sick society. That someone is a burden on others or expensive to care for does not make it ethical to impose death on them. A simple dislike for living in a dependent state is not a good enough reason to ask others to help you kill yourself. Food and fluids are basic human care, but they've been redefined. Statutorily, they are now considered medical treatment and can be taken away with all the other medical treatment. At a World Federation of Right to Die Societies meeting in 1984, Australian bioethicist Helga Cuse talked about the strategy of the Right to Die movement. She said, and I quote, "If we can get people to accept the removal of all treatment and care, especially the removal of food and fluids, they will see what a painful way this is to die, and then in the patient's best interest, they will accept the lethal injection." You think that's far-fetched, or some people do, but did anybody see the Dr. Phil show a couple of weeks ago in which he featured a woman named Annette Corriveau? She was the mother of two severely disabled adult children who had been taken care of in a home for many years, but she hadn't taken care of them. She would go to visit them every couple of months. She wanted the right to have them euthanized. Also on Dr. Phil's show was Jeffrey Feiger, who happened to be the attorney for Jack Kevorkian, our friendly mass murderer in Michigan. And he sided with Annette Corriveau. And he said that she was being asked to make a horrific choice, to remove their feeding tubes and starve them to death or leave them in the care home where they'd lived for decades. Living was, the worst option. And he urged people to be in favor of giving them a lethal injection. Dr. Phil then polled the audience. And 90% of them thought that these two young men should be given a lethal injection. 90% of Dr. Phil's audience. I don't watch Dr. Phil anymore. Perhaps we're not quite ready for the lethal injection, but when you look at what happens to a person who starves and dehydrates to death, and I always put starves first because it just comes naturally when you're talking food and hydration, but actually what will happen first is dehydration. You're going to die from no fluids. It's like being in a desert. It's a bumper sticker slogan when you hear death with dignity to describe taking away a person's food and water and letting them die. There is no dignity in dying that way. It takes from 1 to 3 weeks. Here's a description from a court case. The mouth dries out, the lips and the tongue crack and bleed. The lining of the nose dries out and bleeds. The skin becomes dry and scaly. Urine becomes highly concentrated and burns the bladder. The stomach lining dries out, causing dry heaves and vomiting. The patient suffers convulsions as brain cells dry out. Thick secretions plug the lungs as the respiratory tract dries out. The muscle of the heart is consumed as it searches for protein and finds it in muscle tissue. Finally, the patient dies. No matter how the law defines them, food and water do not become medical treatment because we put them through a tube, any more than penicillin or Pepto-Bismol become food when we put them through it into their mouth. So an insertion or implantation of a feeding tube may be a medical procedure. It is a medical procedure, but it's a very ordinary and usual procedure. And once it's in place, the food and water are just basic care and nutrition. There was a case of Paul Brophy in 1986. He was a firefighter in Massachusetts, and the court ordered that his feeding tube could be clamped or removed. Neither was done. When he began to have seizures, they put anticonvulsant medicine through his tube. When he had stomach bleeding, they put antacids into the tube. When he, to make him comfortable, they put laxatives in the tube. So it was obvious that it wasn't the feeding tube that was the problem. It was Mr. Brophy that was the problem, and they wanted to get rid of. Let's be clear, nobody is going to force food and fluids on someone who refuses them. That would be assault and battery. Nor are we going to force them on someone who is clearly dying and when they won't have any benefit for the patient. We will give them what they need to keep them comfortable in those circumstances. But what we're talking about here, let's be clear, is taking away food and fluids in order to make the person die. The question is always that we have to ask ourselves is, will this person die of dehydration? If the answer is yes, then we have to provide them with food and fluids. Another thing that you never want to say no to in your living will is a ventilator or in your advance directive for healthcare. Just as it's unwise to refuse food and fluids, refusing a ventilator is very unwise. When you're sick or injured, you may need this. It may save your life. And usually, and most people don't know this, but usually a ventilator is only used for a short period of time to get a person over the worst of, say, a lung injury or a difficulty breathing, and then they are weaned off of the ventilator. And some people are afraid of tubes. And so they say, I don't want to be intubated. Well, there are modern ventilators that are called non-invasive positive pressure ventilation, NPPV. It uses a face mask, a whole face mask, and pressurized oxygen, so you don't have to be intubated. And this is often used with patients with end-stage lung cancer because it makes them much more comfortable, and they usually don't need to use as much sedation or morphine when they use NPPV. So there are many reasons why you might want a ventilator. Fear of tubes should not stop you from wanting a ventilator if you need it, because air hunger, breathlessness is much more uncomfortable. Patients with chronic or acute respiratory failure have shown improved lung function and better sleeping with an NPPV. No one can be kept alive endlessly on ventilators, no matter what you have heard. When a person on a ventilator dies, their blood circulation ceases. There's no longer an exchange of oxygen and carbon dioxide, and the signs of death are apparent. They begin to deteriorate. So you cannot keep a person alive forever on a ventilator. They die on a ventilator just like they do on any other kind of medical treatment. Also, don't refuse CPR unless there's a really good medical reason why you would not want to be resuscitated. CPR involves chest compressions, electric shock, breathing tubes, and resuscitative drugs. A DNR is a do not resuscitate order, but these can be broadly interpreted to mean much more than the person who had the DNR put on their chart means. It could reduce or eliminate doctor's visits or nursing care or treatments, and some patients are even allowed to die in reversible situations, such as if they're choking on food, they might not clear an airway, or if they give them the wrong medication. And this happened to a woman in Montana. She was given the wrong medication, and they could have saved her life by putting her on a ventilator until she recovered from the overdose. And they didn't do it because she had a no ventilator order on her, and a DNR order on her chart. So they did not even correct their medical error. A DNR order should always be taken off of a person if they're going in for surgery, so that they will be resuscitated if they happen to stop breathing or lose their heartbeat while they're in surgery. There's certain general principles for making moral medical decisions. And the most important one, I think, is that we should always err on the side of life. We can always try something and stop it if it's not having the desired effect. But you should always give life the benefit of the doubt. Every medical decision must be individualized because we're all individuals and our needs are different. It's the doctor's duty to discuss with the patient the available treatments and what he thinks will do the patient some good or what's useless. But it is the patient's right to make the decision, or the patient's decision maker's right to make the decision about whether or not they will accept a treatment that is useful. The object and motivation for administering pain medication must be to relieve pain. Death must never be sought as the outcome of giving pain medication or sedation. And of course, do no harm. Doctors have a responsibility to try to dissuade patients from asking to be killed by dehydration or when they know something else will save their lives. But if they think that a decision that a patient is making is an immoral one, they can follow their conscience and remove themselves from the case. They do not have to care for a patient. They can ask the patient to find another physician, or they can remove themselves from the case and another physician can be assigned. But there is no reason why. Nurses, however, do not always have this protection. You can do it, but your job might be at stake. Now we're going to talk about futile care. Futile care is something that may be lurking in your hospital that you know nothing about until it happens to you. Futile care is based on the theory that when a patient reaches a certain stage of illness, injury, or age, anything other than comfort care is considered futile and withheld or withdrawn. So not all end-of-life treatments are appropriate. Some are truly useless. and those nobody has an obligation to provide. But in fetal care cases, it's the patient who's considered useless, not the treatment. Boiled down to its essence, this is heartless euthanasia. I want to look at the worst fetal care law and the worst fetal care policies in the nation. They are in my state of Texas. In 1999, Texas added to their medical decisions law a fetal care or a medical futility amendment. And this allows hospital bioethics committees to take and decide a dispute between a patient or the patient's family and a doctor when there's a disagreement about whether or not treatment should be provided. If the patient wants treatment and the doctor doesn't want it, it goes to the ethics committee, and the ethics committee makes the final decision. There is no appeal. If the ethics committee rubber stamps the doctor's decision not to treat, then the patient is given 10 days to get out of that healthcare facility, or all, food and water included, all treatment will be stopped. And the patient will be given only comfort care, which means they'll probably be sedated until they die. There is, I repeat, no appeal to this death sentence. You're out in 10 days, or you're dead in 10 days, or after the 10 days they will start to kill you. The Texas law strips patients of the right to make their most important health care decisions and gives it to strangers on a hospital committee. In March, Elizabeth Graham is here, and she is the president of Texas Right to Life. In March, they got a call from a family of a man named Willie, who came under the Texas fetal care policy, and his family wanted him to live. He told his daughter, "Fight for me, baby. I ain't done living." He had pneumonia and leukemia when he entered the hospital. They treated him for about 4 weeks, and then they decided it was futile to treat him anymore, even though his family insisted. They had his durable power of attorney in hand, appointing an agent, and they asked the hospital to continue treatment, and they refused. Finally, on the 8th day, the family contacted Texas Right to Life, and they tried everything they could to save this man's life, but neither the law nor time were on their side, and Willie died. Be wary of everybody. A bill to eradicate the 10-day rule was introduced in the Texas legislature in 2007, but the Catholic Conference surprisingly came out in favor of fetal care theory. They said, Bishop George Amond of the Diocese of Austin, speaking on behalf of all Texas bishops, declared that a hospital should have the ultimate say. Quote, "We realize that families, through no fault of their own, are really not able to make those decisions because of their involvement, because of their emotions," unquote. That is utterly contrary to what the Catholic Church teaches. The Catholic Church teaches in the Catechism that the ultimate decision to accept or refuse treatment belongs to the patient or those legally entitled to speak for the patient. I try my best not to speak ill of religious leaders, but the bishops in Texas are dead wrong. Patient statements that what I wouldn't give for one more day, or I ain't done living, they ought to be respected. Life is priceless. Even if it's just another day, it is priceless. Not all hospitals have adopted fetal care policies. And those that have not and are trying to provide good care for patients have a challenge on their hands because they're going against the flow. And it's never easy to swim upstream when everybody else is going the other way. Advance directives, some are bad, some are good, but most are dangerously flawed. I think I've covered some of the flaws, but it's ridiculous to ask someone to make a decision based on a prognosis that you might die in a certain amount of time. Larry the Cable Guy, one of my most favorite irreverent comedians, told a joke the other day, and I laughed. It was really funny. A doctor calls a guy and he says to him, I've got really bad news and then I've got worse news. And the guy says, well, okay, what is it? And the doctor says, well, you've only got 24 hours to live. And the guy says, well, what could be worse than that? And he says, I forgot to call you yesterday. You know, that's funny. And Larry always says, now that's funny. But what's really ridiculous is believing that you're going to die on schedule, so that you might as well not even try. You might as well give up and die. My husband has a really good friend. Went to high school with them. They celebrate all their birthdays together. They go golfing all the time. Larry, this man's name is Larry too, Larry Larson, was told last March that he had 4 weeks to live because he had pancreatic cancer. He went golfing with my husband last week. That's 14 months later. So you just don't know. They can tell you all kinds of things, but you don't know. Only God knows when your time is up. Don't give up ahead of time. And don't show up uninvited. You need to have an invite. You know, you don't want to show up and God say, well, what are you doing here? Okay. So it is never wise. It is never wise to take someone's word for it that you're dying. Call the healthcare instruction. The living will is a written statement of the principal. The principal is the person who makes out a living will or an advance directive for healthcare. And the person that they name to make their decisions for them is called the agent. So when I use those terms, understand what I'm talking about. If you make a directive, you are the principal. The person that you name as your decision maker is your healthcare agent. You know, living wills ought to be invalidated on one simple ground, and that is that you cannot base decisions, sensible, informed healthcare decisions, on guesswork about the future. That should be enough to invalidate a living will. That's the reason we need a power of attorney for healthcare. The protective medical decisions document has all the information that you need to know right along in the package, so I don't need to go into all that information with you. But there's how much time do I have left? Okay, there's two really important things that I want to get into. And one of them is called POLST, Physician Orders for Life-Sustaining Treatment. It also comes under acronyms like MOST, POST, POLST, but they all mean the same thing. They're physician's orders for life-sustaining treatment or scope of treatment. There's a national effort underfoot to control death under the guise of enhancing autonomy. Autonomy is making your own decisions. It's deciding for yourself what you want done. Some aspects of the culture of death are very subtle. POLST is one of those. It sounds so safe. Physician's orders for life-sustaining treatment. But actually what they're hoping you will do is refuse life-sustaining treatment. It's a brightly colored form that becomes the first page of a patient's chart. It has boxes on there to be checked off, refusing or accepting specific medical treatments. A POLST document overrides a patient's previous health care directive. Do not ever answer POLST questions. Facilitators, people who are taught how to ask these questions, may be social workers or clergy with no medical training. They visit the patients and they discuss their treatment options with them or with their decision makers if the person is already incapable of making their own decisions. Then the facilitator checks off the patient's preferences according to the facilitator's interpretation of what the patient or the patient's decision maker meant. There are no witnesses present when this takes place. This was designed by bioethicists. The POLST process is tilted toward refusal of treatment. For instance, under medically administered fluids and nutrition, the first item is no IV fluids. The second one is IV fluids for a defined trial period, and lastly, IV fluids long term. The order that you put questions is very important. The next section, no feeding tube, is the first option. Feeding tube for a defined trial period is the second, and feeding tube long term is the third choice. The facilitators are trained to focus on what the patients would not want. For instance, one of the questions that one of the things they're taught to say is, quote, "We find that most people would not want to be kept alive in a vegetative state," unquote. How many people really know what a vegetative state is? Do you know that 40 to 50% of all people who are determined to be in a persistent vegetative state are misdiagnosed, and they really have some level of consciousness and know somewhat what's going on around them? And what right do we have to call anybody vegetative? They're not beets and carrots and lettuce. They're human beings. They are human beings with impaired consciousness. But when you use terms like vegetative, what comes to your mind? Of course you're not going to want to live like that. Who wants to be a carrot? I just think it is leading people to the answers that are desired, not by the patient, but by the facilitator. POLST involves a coaching process. It's actually not difficult to clarify away someone's wishes by presenting them with realistic medical options, in quotes, realistic. The Respecting Choices program in La Crosse, Wisconsin, which trains a lot of people from all over the country how to be facilitators for POLST, teaches facilitators how to change patients' existing beliefs by explicitly discussing the limitations or consequences of adhering to and acting on those beliefs. In other words, if a person expresses a wish to have tube feeding, they may be told all of the terrible things that could happen. For instance, they could aspirate and get pneumonia and all those things, which, yes, that happens sometimes, and sometimes they do get infections at the site where the tube is inserted. Sometimes, not always. And when that happens, you treat them with antibiotics or you treat them for their pneumonia. But that's not the worst thing that can happen. Dehydration to death is much worse. Elderly people in particular are easily manipulated in a healthcare setting. One day a healthcare provider, a doctor, could tell a patient to, yes, accept the IV tube feeding, and the next day he could show up and some social worker has come and convinced her to check the little box on a POLST form that she doesn't want IVs or any kind of tube feeding, and the doctor's hands are tied because another doctor signed the form. And the doctor who signs the form does not even have to know the patient, ever have met the patient. The person who fills out the form presents it to any doctor, and any doctor can sign it. They have all the dangers of a living will, but one person who is really aware of what POLST is compares POLST documents to living wills on steroids, because they differ in significant ways from living wills also. They're signed by a physician. Living wills and advance directives of any sort, whether they're power of attorneys for health care where you name an agent, or a living will where you write down your wishes, all of those are signed by the principal. A POLST does not have to be signed by the person, the principal. It only has to be signed by a physician, and it can be a physician who's never spoken to the patient. They're effective. The patient can be asked to sign it or be invited to sign it, but it's effective whether the patient signs it or not. So someone could come to the patient's bedside, ask a bunch of questions, and the patient doesn't even know what happened, that they just revoked their advance directive and they've now got a new one on their charts. No witnesses are required. This alone should sound alarms. Our advance directives all require witnesses or notarization. So why would this document override something that's been witnessed or notarized? The POLST carries a lot more weight than your advance directive does. Once signed by a physician, this travels with you everywhere. Gets posted on your refrigerator if you're transferred home so that EMTs can follow it. Do you know that EMTs have to follow the POLST orders written by a doctor they may not know who he is, for a patient they may not know? And if a person is transferred to another healthcare facility, this follows them. And people in that healthcare facility have to follow the orders of some physician they don't know. If the patient didn't refuse treatment, they'll be revisited over and over and over again with the POLST form. Refuse to talk to a POLST facilitator and tell your agent and your family members that you don't want them to answer those questions or sign anything. Now the most difficult part of my talk, and I only have a few minutes for this. How much time do I have left now? Oh, time for questions. Okay. This afternoon, I'm going to talk to you about organ donation and transplantation, so along with patient advocacy.
You're going to reason to stay.